السلام عليكم.
وعليكم السلام ورحمة الله وبركاته.
إن شاء الله تكونون بصحة وعافية. نبدي يعني ننتظر جماعتكم، نبدي من هالساعة واللي يجي هلا بيه.
تمام دكتور.
هاي الصورة تشوف بيها نماذج للسبلنت تستخدم in orthopedic surgery. الفيرست واضحة الصورة تشوفونها؟
ايه دكتور واضحة.
الفيرست هي what we call a Thomas sibling. Thomas sibling used for emergency to support the injured limb to avoid further injuries. محمد يوسف ورامي قصي. الأذر سبلنت what we call it Brown أو Bohler sibling used for skin or skeletal traction in the hospital. This is the second. This is the skin traction kit. This is the skin traction kit. The skin traction هو blaster covered by protective layer. حميد. This is what we call it skin traction. It is a blaster covered by a protective layer with a crepe bandage ended with rope, used for skin traction to apply direct. So this is what we call it skin traction kit, and this is how we apply it. We apply it directly to the skin and the end of rope connected to it. This is what we call it skin traction. The skin traction is a simple way of holding a fracture. Usually it cannot tolerate more than 4 kilograms and commonly used for children or in temporary management of fracture waiting for surgery. So this is what we call it skin traction. And this is how we apply skin traction. We remove the protective layer from the blaster, and we apply it directly to the skin, one medially and the other laterally. The end of the rope is facing the foot, and we fix it by crepe bandage. Every layer of crepe bandage covers more than 1/2 of the previous layer, and we apply it to the skin. Then we apply connected weight to it, and we use it as a temporary way for holding fracture. Can be used with in the word, can be used with Thomas sibling. محمد شاكر. So this is what we call it skin traction. اسمعونا محمد؟
ايه دكتور، بس دكتور اكو طالبة داخلة هنا يعني بالميتينج اسمها صفاء محمود.
هاي بنتي
ما بلغتني ولا هي بالجروب.
لا هذه بنتي مالك. بنتي.
تمام.
This is the skin traction where, when applied vertically, what we call it gallows traction, applied vertically, it's used only for a unit. It should not be used for those who are older than 1 year. So this is what we call it vertical traction or gallows traction. It is skin traction applied vertically. It was used for birth injury for children less than 1 year and for treatment of DDH previously. This is the balanced traction, many pulleys and connected to it, the idea to get what we call it balanced traction. This used previously to prove of much.
It is used as conservative treatment of patient with the fracture of the shaft of the femur and tibia, doctor, and in combined fracture. Previously. Now, most of these patients who need such traction usually treated operatively either by internal fixation or external fixation. Previously, this used. Now, most of the patients with this complicated fracture or who need traction for a long time treated operatively by either internal fixation or external fixation. Clear? Clear, doctor.
Yes. This is the best and the simple way for balanced traction. This is the best and the most easy way to get balanced traction. The elevation of the end of the bed and the weight of the body will pull in one direction and the weight will pull in other direction. This is the simple way of balanced traction. If we need more complicated way for traction, it is better to treat the patient operatively. Usually there is pillow under the limb, injured limb, and we elevate the end of the bed. محصلة وزن الجسم تسحب باتجاه والثقل يسحب باتجاه. We get what we call it balanced traction. This is the most simple way for getting balanced.
دكتور بس سؤال.
Yes, تفضلي. Yes, أسمع.
هذا الثقل ايش قد راح يكون وزنه من وزن الجسم؟
الوزن من الجسم راح يكون 1/10 من البادي ويت.
يعني أكثر شيء ممكن 5 كيلو؟
أكثر شيء لازم يكون
أقل عن
كيلو. الأفضل أن يكون
يعني أذكر بالأفضل أعرف كان 5 كيلو أكثر شيء.
الأحسن أن يكون 4 كيلو أقل بعد.
إيه هو لأن التوكة يعني بعد أحس لأن هون مع الجاذبية أقوى.
الوزن اللي نستخدمه بالسكين تراكشن لازم يكون أقل من 4 كيلوات أو أقل من 5 كيلوات أيضا يمشي صح. إذا نحتاج أكثر من 5 كيلوات لازم نتحول إلى السكيليتال تراكشن.
تمام دكتور.
السكيليتال تراكشن هو insertion of pin in the bone connected to it. ولذلك السكيلي تراكشن أما يستخدم temporary waiting for surgery أو كفيرست ايد أو in children in management of children اللي أوزانهم أقل من 40 كيلو or to ensure bed rest يعني فقط نريد نربط المريض للسرير فنستخدم السكين تراكشن. إذا كنا نحتاج أكثر من 5 كيلوات for long duration we should go to the skeletal traction. واضح؟ واضح دكتورة؟
شكرا دكتور.
يعني.
شكرا دكتور مش واضح.
وسام This is the skeletal traction. Pin inserted under aseptic technique inside the bone, connected to it. The most common site for skeletal traction was distal femur, the proximal tibia, and the distal tibia, or even calcaneum sometimes used for skeletal traction. The skeletal traction used permanently for conservative treatment of fracture, or sometimes for a few weeks until the skin condition is improved. إذا كان أكو laceration in skin, wound in skin, or compartment syndrome for just we wait until the condition of the patient improve and then when go to the operative treatment, other operative treatment. So this is what we call it skeletal traction. The skeletal traction we can't put weight as much as we want, but as a general هي 1/10 من البادي ويت. يعني دائما نستخدم 1/10 من البادي ويت. فاللي كان وزنه مثلا 70 كيلوغرام نقدر نستخدم 7 كيلوات. وممكن نستخدم أعلى شوية in the first day, then we reduce it in the second day, and we continue 1/10 من البادي ويت. أكو سؤال هنا
دكتور بس
yes.
دكتور يقظة من أخذنا هذا السكيل تراكشن قال إنه 1/6 of the body weight. 1/6 of the body weight.
هذا for one day.
ما أدري والله يعني حتى هو بشكل يعني حتى بيشرحها على
محمد
to the fracture side.
محمد هذا إذا كنا نستخدمه to reduce fracture. هذا السكيليتال تراكشن يستخدم to hold fracture. تعرف شنو to hold fracture? To preserve the position of the bone in its position. في بعض الحالات نستخدمه to reduce fracture. إذا نستخدم to reduce fracture نستخدم 1/5 من البادي ويت أو 1/6 من البادي ويت in the first day under observation with image intensifier أو X-ray until the fracture is reduced, then we reduce it to the 1/10 of the body weight. واضح؟
واضح دكتور.
Yes. مرات يعني تنشرح فكرة ما توصل واضح. Enumerate the immediate soft tissue complication associated with the fracture. دائما تتذكرون بأن most dangerous complication هو الcompartment syndrome. Compartment syndrome هي most dangerous. Compartment syndrome هي elevation of pressure within the tissue. This will lead to ischemia. Compartment syndrome هي most dangerous, and you can see there's abrasion in skin, wound, necrosis in skin. All this is complication for a fracture. This is picture for traction. هذه صور قديمة مأخوذة من كتاب ما لها قيمة. This is what we call it brace. This is what
functional brace. Yes.
Functional brace أو brace. البريس ممكن أن يكون fabricated يعني صناعي جاهز, or we can do it from POP. We can do it from POP. It used to support the fracture. It used to support joint. It used to support limb. إذا كان أكو nerve injury مثلا foot drop أو wrist drop, we use it as a support to prevent stiffness in bad position. But this is what we call it a brace. It's available in different design, different shape, according to the need in the limb. This is the most common material we use it اللي هي الجبسون أو plaster of Paris. POP. plaster of Paris. الاسم مشتق من بلاستر وباريس، باريس المدينة المشهورة. And it is ready, يعني it is prefabricated already. ممكن تكون بشكل 2 inch أو 3 inch أو 4 inch أو 6 inch أو 8 inch أو 10 inch, available in different size و preserved in package. أهم شيء أن تكون هذا.
دكتور
نعم.
بس شوية الشرح شوية يصير تبطئ، أنا مو مركز معك.
أوكي. هذا الباكج usually يعني لازم يكون protected يعني not penetrated. أي penetration بالباكج يسرب الرطوبة إلى الجبس ويفقد فاعليته، فلازم يكون well sealed. يعني مهم جدا تتأكد بأن يكون well sealed. و it can be applied in different shape. ممكن أن تكون بشكل back slab أو ممكن تكون بشكل complete POP. هذا الجبسانة تنفتح الغلاف مالتها الموجود، وإذا كنا نريد نسويه بشكل باك سلاب نختار الطول اللي نحتاجه والعرض اللي نحتاجه. دائما الطول لازم يكون الجوينت above والجوينت below. تفكس the joint above and joint below الطول. والعرض لازم يغطي 3/4 السيركمفرنس of the limb. فإذا نحتاج مثلا اللور لمب لازم نستخدم 10 أو 12 بالعرض، وإذا كان بالأبر لمب نستخدم 4 أو 6 according to the need. فالعرض يحدد اللمب، يعني لازم نغطي 3/4 السيركمفرنس، والطول يحدد لازم يكون الجوينت above and joint below إذا كنا نريد نستخدمه بشكل باك سلاب. to apply POP first الفراكشر لازم يكون reduced. clear؟ الفراكشر لازم يكون reduced. واللمب should be maintained in position. لازم اكو اثنين يحملون اللمب longitudinally in traction بحيث ما يصير بي displacement again. فأول شيء هي الفراكشر يكون reduced أو undisplaced. Second, reduction should be maintained by traction by two assistants. واضح؟ The third step,
واضح دكتور.
the skin should be protected by layer of cotton. Layer of cotton. أما نستخدم القطن اللي هو الأكثر مادة متوفرة هو القطن. فلازم السكين should be protected by layer of cotton. أو ممكن أنه في بعض الأحيان بشكل تيوب جريب مثل الجوارب يعني تتدخل double layer of tube grip أيضا protective layer. فالسكين should be protected by cotton or tube grip. Okay. third step إذا كان نستخدم باك سلاب فلازم نختار الطول المطلوب والعرض المطلوب. الطول المطلوب لازم يكون joint above و joint below. العرض المطلوب لازم يكون it cover 3/4 of the circumference of the limb. الغاية أنه to support the limb enough و allow part of the limb to allow oedema to expand بحيث ما يصير عندنا compartment syndrome و ischemia و pressure to the limb.
To avoid.
Yes, to avoid أو avoid swelling والأوديما لأنه الأوديما هي البريكارسر اللي ممكن يسوي لنا compartment syndrome. وأوديما in the tissue هذا ممكن يروح even to gangrene and ischemia إذا أهمل يعني. بعدين هذا الجبس اللي اخترناه نختار الثخن المطلوب. الثخن المطلوب إذا كنا نستخدم باك سلاب فبالنسبة للأبر لمب عادة نستخدم 10 إلى 12 طبقة نخلي. إذا كان لور لمب 12 إلى 16 طبقة حتى يكون أقوى شوي. طبقات. بعدين هاي الطبقات اللي حددناها والطول اللي حددناه we immerse it in water يعني نغطسه بالمي. نغطسه بالمي. المي يفضل أن يكون مي الحنفية يعني مو مي حار ولا يكون مي بارد. إذا حار يصير الجبس حار أكثر وإذا بارد يتأخر التصلب مالته شوي. فمي الحنفية دائما واحد يستخدم. ندخله بالمي إلى أن يأخذ المي بشكل كافي وبعدين نرفعه إلى أن يروح كل المي الزايد من عنده. واحد دائما يفضل أن ما يعصر الجبس لأنه إذا تعصر الجبس تطلع المادة الفعالة من عنده فتخلي المي ينزل الحالة. أوكي. وبعدين نخليه على الباك سايد أوف ذا لمب نغطي 3/4 ونثبته بكريب باندج بنفس الطريقة أنه نلف لفة وتغطي 3/4 السيركمفرنس أوف ذا لمب. هذا اللفاف اللي نستخدمه. بهالطريقة هذه we maintain traction و counter traction إلى أن يتصلب الجبس. الجبس حتى يتصلب يراد له 4 إلى 5 دقائق حتى يتصلب. بعدين we put the limb in sling إذا كان upper limb أو إذا كان lower limb نخليه over below we elevate it over below. هاي الطريقة اللي نستخدم بها الباك سلاب. وأيضاً after application of POP we should check the circulation. لازم نتأكد بأن circulation is well بحيث venous return capillary return is normal. أما إذا كنا نستخدمه بشكل complete POP فأيضاً we reduce the fracture, we maintain the reduction, we protect the skin by protective layer. بعدين نطلع الجبس نحدد يعني نختار الجبس اللي نحتاجه والنهايات مالته تكون طالعة يعني واضحة. بعدين we immerse it in water إلى أنه كل الفقاعات تروح. بعدين نرفع إلى أن يروح كل المي الزايد من عنده ونبدأ اللفة من الديستال بارت to the proximal part. وكل لفة تغطي نص اللفة السابقة. الغاية من أنه كل لفة تغطي نص اللفة السابقة حتى ما تصير منه حافات من الداخل وتؤدي إلى بريشر ألسر. ونستمر بهاي الطريقة إلى أن نوصل proximal to the joint above ونستمر بالجبس نخلي عدة طبقات إلى أن نخلي حوالي 8 إلى 10 طبقات بالأبر لم و10 إلى 12 طبقة باللور لم. الجبس ممكن أن يكون بلوني، ممكن يكون above knee، ممكن أن يكون spiker to the chest، 1.5 spiker، ممكن أن يكون below elbow above elbow. بالشكل الريدة دائما نقدر نخلي الجبسونة. المهم دائما أنه we should not apply the POP tightly. We should not apply the POP loose. إذا كان tight it lead to ischemia. إذا كانت loose it lead to displacement of fracture. This is the most common material we use it in the orthopedic POP, plaster of Paris. Any question about application of POP? عندكم سؤال؟
العفو دكتور، بس
Yes.
بالنسبة للمادة المصنوع منها الPOP،
المادة المصنوع منها هو كالسيوم سلفات. كالسيوم سلفات. الكالسيوم سلفات هي الحجر المشهور عندنا اللي نسميه احنا الفرش او الحجر الابيض.
هي دكتور هي الكالسيوم سلفيت هيدريت.
الحجر الابيض هي الكالسيوم سلفات. الحجر الابيض هو هايدريتد كالسيوم سلفات. كالسيوم اللي هو هايدريتد كالسيوم سلفات. الجبسونة هي مونو هايدريتد كالسيوم سلفات. مونو هايدريتد كالسيوم سلفات. الجص اللي احنا نستخدمه بالبلد، الجص اللي نستخدمه هو دي هايدريتد كالسيوم سلفات. واضح؟
شكرا دكتور.
زين دكتور، بالامتحان مطلوبة
مطلوبة
هاي البريبريشن؟
ما مطلوب. ها؟ شلون؟
البريبريشن مع الابلكيشن مع البلاستر بارس مطلوبة.
هذا دائما هذا أهم سؤال تسألون عنه. هذا أهم سؤال تسألون عنه، لأنه أهم شيء أنه المقيم يعرف شلون يخلي جبسونة. واضح؟
تمام دكتور.
المادة اخترعت في أمستردام وسميت باريس، سبب أنه كانت اخترعت في زمن نابليون عندما كان محتل أمستردام، محتل أوروبا كلها. This is the external fixation. اللي هي pin proximal and distal to the fracture connected outside the body. This is the external fixation. The common use for it هو
combined fracture.
الأوبن fracture أو compound fracture. وthis is example of internal fixation اللي نستخدمها. ممكن أن يكون بشكل سكرو، ممكن يكون بليتانت سكرو، ممكن أن يكون intramedullary nail، ممكن يكون nail with locks screw، وممكن أن يكون modified blade with screw مثل الديناميك هيب سكرو. This is the common method of fixation. ممكن أن يكون كي واير بشكل. الكومن تو complication اللي يصير هي دائما الانفكشن، هي الموست سيريس complication. الأذر هو الميكانيكال failure. Any delayed union or non-union might lead to mechanical failure and the breakage of the plate, avulsion of the screw. We call it mechanical failure. This is example of fracture in a blade. You can see long blade, heavy blade, and it's broken. لأنه مهما يكون minor repeated trauma to the blade lead to break in a blade. This is what we call it stress phenomena or stress fracture. This is example of fracture in radius and ulna. You can see the X-ray AP and lateral involving the proximal joint and distal joint. And we can see there's transverse fracture in both radius and ulna at same level displaced and overlap. Displaced and overlap. What's the best method of treatment for this injury?
Open reduction and internal fixation and physiotherapy.
Excellent. This is the best method. لأنه trial to reduce it usually will lead to displacement of the other, and it lead to some malunion. Any malunion will interfere with the pronation and supination. In the adult, the best treatment usually هو open reduction and internal fixation. Open reduction and internal fixation. In the forearm, we want to get perfect anatomy to get perfect function. The perfect function هو most important هو pronation supination. Any malunion will lead to impairment of pronation supination, and this will interfere with the work, with movement. This is example of Montagia fracture. You can see there is a fracture in the proximal third of ulna with dislocation of head of radius. Dislocation of head of radius. So this is what we call it Montagia fracture. The principle of treatment usually here open reduction and internal fixation.
Internal fixation. To restore the length of the ulna. To restore the length of the ulna.
The length of ulna, and to reduce if we restore the ulna, we can reduce the dislocation in head of radius. This is X-ray for spine and calcaneum, and you can see in the calcaneum there is a fracture in the calcaneum, and there is wedge fracture of the lumbar spine, first lumbar spine. This is what we call it two injuries. Sometimes if patient jump from stair or jump from high altitude, he will fall in his heel. And this fall in heel will broken the heel and usually associated with a flexion of spine. Other flexion in spine will lead to wedging of spine. This is two fracture caused by same mechanism, what we call it two injuries. It is always, if we have patient with fractured calcaneum, we should look for injury in the spine. This is example of lesion in the soft tissue. You can see there is ossification in the soft tissue. This ossification in the soft tissue, we name it as myositis ossificans. Myositis ossificans. Always we should concentrate on the bone, joint, and soft tissue. Sometimes the pathology in the soft tissue. So this is example of the pathology in the soft tissue. This is example of open fracture. You can see the exposed bone, lacerated wound, bleeding, contamination of the wound. This is example of the open fracture or compound fracture. The best method of stop bleeding in such injury is
we should start with the clean dressing and pressure,
yes,
and the tourniquet to the proximal to the fracture and tight enough to close vessel and ligation of the vessel.
The best method to stop bleeding here, direct pressure to the wound with clean dressing. This is the best method to stop bleeding. Rarely we need to do tourniquet. The tourniquet is good method for stop bleeding, but carry many hazards. The hazard of tourniquet,
risk of ischemia. Risk of ischemia
هو most dangerous. It might cause nerve injury. If we do it for a long time, we lead to gangrene of the limb. If we do it light pressure, usually light pressure will create more bleeding and allow arterial injury to come and prevent the return of venous circulation. But this will increase bleeding. The tourniquet is risky and should be used with caution. أهم caution هو time, pressure, position. All this is very important in application of tourniquet. أما إذا المريض وصل للردها, in the hospital we can ligate the artery, we can repair the artery, we can cauterize the artery. But as a first aid, the most important تذكرون هو direct local pressure. This is the tourniquet. والcaution قلنا هي most important caution هو التايم والبريشر، مهم جدا. إضافة إلى السايتس. السايت التورنيكا should applied over a single bone not استخدم over double bone. يعني ما نقدر نخلي تورنيكا بالفورارم، لازم نخلي تورنيكا بالارم. يعني نخلي تورنيكا above knee، ما نقدر نخلي تورنيكا over the tibia and fibula، لأنه لازم يكون over a single bone. We apply it over two bone عادة ما تكون end with failure، لأنه it will lead to blood loss.
not tight enough.
ما يكون tight enough، ما يسمح sufficient compression to the artery.
Yes.
هذا النوع البوليت انجريز، وهذا العلاقه بالثيوري مال البوليت انجريز. الدمج of the bullet injury usually depend on pathophysiology، اللي هو يعتمد kinetic energy تساوي velocity square of the velocity multiplied by the weight of the body. فمهم جدا هي velocity of the missile. كل ما تزداد velocity of the missile يزداد kinetic energy ويزداد الدمج. فالبولت اللي سرعتها 100 متر بالثانية kinetic energy مالتها راح يطلع 10,000. بينما الميسايل انجري اللي سرعتها 10,000 متر بالثانية مثل الطلقات الحديثة راح يكون الكاينتيك انرجي مالتها 100 مليون. فواحد يتخيل الفرق بالكاينتيك انرجي، والكاينتيك انرجي هي اللي تؤدي الدمج in the tissue. usually it penetrates the tissue and will create cavity in the tissue. والcavity will collapse within few milliseconds, and this will suck all the dirt around. For all the bullet injury or shell injury is heavily contaminated. Now this is the theory of cavity. When the bullet enter inside the tissue, it will create cavity, and this cavity will collapse and it lead to suction of dirt and contaminate the tissue. Usually the bullet injury will cause massive damage to the bone, fragmentation to the bone, and multiple shell in the area. All these increase the risk of infection. And always the preferable method for treatment of open fracture بالبولت injury هو external fixation. This is X-ray show bullet in the region of the knee. Before any trial for any treatment, we should do AP and lateral with marker on skin to assess the depth of the bullet. This bullet might be inside the joint or outside the joint in the soft tissue. So always we should have two X-ray with marker on skin to assess the depth of the bullet injury. We should not treat patient on single view X-ray. And this is X-ray for shoulder and arm with bruises. This is what we call it, the bruises, bleeding in the soft tissue. Usually this bleeding is transient and it will subside spontaneously, and the blood and hematoma in the tissue will resorb spontaneously most of the time. This patient had fall on the ground and she developed fracture in humerus مثل ما واحد يتوقع. الclinical sign we should assess, most important here to assess nerve distal to the injury, nerve function distal to
هو اللي wrist drop.
nerve injury distal to the injury. النيرف injury هي radial لأنه near, median مهم جدا. Always we should check the motor and sensory. Motor and sensory. The sensation, the motor usually depend on movement, and sensation on pain sensation. We can use pinprick. The other هو assessment of circulation distal to the injury. The most important to assess radial pulse and
brachial artery.
The brachial artery, the radial pulse we check it, and capillary filling. Capillary filling is very important.
Yes.
This is the X-ray for this patient. You can see there's butterfly segment. That's what we call it comminuted fracture. If the fracture more than 2 segments, we name it as comminuted.
Comminuted.
Yes. Checking for radial nerve injury, he asked the patient to do dorsiflexion.
Dorsiflexion of the wrist and finger.
Yes, we asked the patient to do dorsiflexion. If he can't do it, this excludes radial nerve injury. بس أيضا دائما واحد يخلي بباله لأنه أكو possibility injury للميديان نيرف والألنر نيرف. الميديان نيرف هي purely the tip of index purely supplied by median nerve. We can use pinprick in the tip of index. And the tip of little finger is purely supplied by ulnar nerve. We can assess the sensation in the tip of little finger. This is the wrist drop. And the common cause of it was radial
nerve injury.
This is swelling of the arm and elbow with what we call it S-shaped deformity sometimes. This is feature of what we call it supracondylar fracture in children. The supracondylar fracture in children is common.
It's very common and important.
Importantly, I know it is emergency. There is liability to
ischemia.
Artery cause compartment syndrome ischemia. واكو possibility ايضا للنيرف injury including median, ulnar nerve or radial nerve. How we describe this injury? X-ray.
Doctor, it is this is X-ray, a plain X-ray, transverse supracondylar fracture with posterior displacement and overlap, which we call S-shaped deformity.
ممتاز. So this is displaced supracondylar fracture, overlap, transverse, posteriorly displaced. So this is typical or common type of injury in the supracondylar fracture. And what's the main clinical sign we check for?
We should check for radial pulsation and capillary reflex, and we should check for radial and median nerve and ulnar nerve, sensor and motor.
Excellent. دائما واحد يتذكر in any fracture, in any injury, the most important here to assess the function distal to the fracture. The function distal to the fracture here, capillary filling, the pulse distal to the injury, circulation distal to the injury, and nerve function. The nerve function here, motor and sensory. بأغلب الأحيان قد يكون أكو صعوبة بالتحريك نتيجة الفين. We should depend in this condition on sensation. Sensation مثل ما ذكرنا التip of index للميديان والtip of little finger for the ulnar nerve. إضافة للchecking for the wrist drop. Yes. This is what we call it cubitus varus.
We call varus deformity, gunstock.
Gunstock deformity, varus deformity of the elbow. This common complication of
supracondylar fracture.
Supracondylar fracture. This is common complication of supracondylar fracture. Most of the time it is just cosmetic. It wouldn't interfere with function of the limb distal to the fracture. بينما الvalgus deformity of the limb, if the limb displaced away from midline, this will lead to stretch on the ulnar nerve medially, and this will lead to delayed ulnar nerve pulse. الvarus benign completely, بينما الvalgus carry risk of damage to the ulnar nerve in the future. This is common complication of supracondylar fracture. This is what we call it Volkmann contracture.
Yes, it is Volkmann.
This is what we call it Volkmann contracture. The Volkmann contracture هي post compartment contracture. Post compartment syndrome contracture. يعني احنا كان عندنا compartment syndrome والcompartment syndrome صار fibrosis of the muscle or injury to the, and sometimes associated with injury to the nerve, and it will lead to this compartment, this contracture. A contracture characterized by severe
by hyper extension of the metapharyngeal and flexion of the interphalangeal.
Yes, هذا نتيجة الcontracture of the flexor muscle, deep flexor muscle. لأنه deep flexor muscle affected more severe than the extensor muscle. So this will lead to flexion of the interphalangeal joint, hyperextension of the MB joint, and the flexion of the wrist joint. So this is what we call it is Volkmann ischemia, or ischemia following compartment syndrome. Ischemic contracture following a compartment ischemia. So this is common وسيريس complication، وأغلب الأحيان هي تحدث عندنا نتيجة التايت كاستنج، بلخص المجبرين مع العرب اللي يخلون تايت كاست أو تايت dressing over the limb. So this is the treatment of compartment syndrome. Here, fasciectomy. We should release the fascia up and downward, and we improve, by this we improve the circulation. So this is what we call it fasciectomy. When we release the fascia, the pressure will disseminate and the circulation will improve immediately. Always we should do fasciectomy yearly. If we do fasciectomy late, after 12 hours or more, this will just, we expose necrotic tissue to the external environment. The compartment treatment by fasciectomy should be urgent. We should not delay it. This is a fracture in the neck of the femur. This is what we call it intracapsular fracture, neck femur. Usually this will occur in old age group, result from osteoporosis of the bone. And this common in old age, بلخص old female. And most of these patients will need surgical treatment to allow early mobilization of these patients. لأنه these patients usually liable for DVT, pulmonary embolism, bed sore, and hypostatic pneumonia. So we should mobilize the patient by yearly surgical treatment if there's facility for surgery. This is following ground. The following ground easy in old age group. Most of the patient had osteoporosis, vision defect, hear defect, nerve defect. For always they are liable to fall on the ground. If they have osteoporosis, the neck of the femur broken easily. And this is the replacement, urgent replacement for the head by prosthesis, what we call it osteomorph prosthesis, to allow patient for early mobilization. This is الانتراكابسولار fracture اللي شفناها سابقا. Usually the bleeding will limit to the capsule of the joint, and there is no bleeding in the soft tissue. While if there is intertrochanteric fracture, distal to the capsule, extracapsular, there is bruises and bleeding in the soft tissue. This is in favor of intertrochanteric fracture. And this is the X-ray for this patient. There is a fracture in the intertrochanteric neck femur, here extracapsular. بينما الانتراكابسولار, this is the region of intracapsular fracture. An intertrochanteric fracture also occur in all age group, عادة ما يكون osteoporotic. This fracture can treat it conservatively, but the trouble, if we keep the patient in long duration in the bed, usually this will lead to DVT, pulmonary embolism, hypostatic pneumonia, and bed sore. The preferable treatment دائما هو الأوبر reduction and internal fixation by dynamic hip screw, by locked intramedullary nail, or by even external fixation can be applied. This is external fixation used for intertrochanteric fracture neck femur. This patient treated conservatively, and you can see the shadow of POP here. And the bone is still displaced and overlap. But this fracture in the tibia and fibula displaced and overlap. Do you agree about this treatment? Usually we don't agree about this treatment, and preferable دائما هو الأوبر reduction and internal fixation. This is what we call it genovirus. Geno varus deformity. But this is varus deformity of the knee joint, the right knee joint, the left straight, while the right deviated medially. This means that there is unilateral varus deformity of the knee joint. This results usually from injury. When you call unilateral, usually it results from injury. Why bilateral عادة ما تكون physiological أو systemic disease in children or physiological أو result from ricket. The unilateral usually it result from injury, either fracture around the knee joint, or it result from damage to the epiphyseal plate by infection or by trauma. Now this is varus deformity of knee joint. It results from osteomyelitis. This is X-ray for the hip and pelvis, and you can see there is lytic lesion in the proximal part of femur and compare with normal side with L-defined margin, and there is no perosteal reaction. This suggests that there is a tumor erode the bone rapidly without any perosteal reaction. For this in favor of secondary metastasis. The primary bone tumor الcommon هو Ewing sarcoma or osteosarcoma. Both of them will cause perosteal reaction, and usually they are affect children. While in old age group, the common tumor which affect the bone lead to osteolytic lesion without perosteal reaction was secondary metastasis. Secondary metastasis, the common site were breast, bronchogenic, prostate, thyroid, and kidney, a common origin to the bone metastasis. This patient fall on the ground and develops severe pain in the shoulder with inability to move his upper limb, and usually he come holding his limb. This is the typical picture of anterior dislocation of the shoulder. Anterior dislocation of the shoulder. The important investigation هو X-ray. The X-ray should be taken in AP and axillary view. By the X-ray, we can assess the X-ray to assess the displacement and type of displacement. And this is picture for the same patient. And this is X-ray for shoulder dislocation. You can see the head go outside and displaced to the medial side and inferiorly. This is anterior shoulder dislocation, anterior shoulder dislocation. This is the way to reduce the shoulder dislocation. وانتم مرت عليكم بالمحاضرة اكو 3 طرق تستخدم للريدكشن of shoulder dislocation. الكمن هو الكوخر ميثود اللي هي anesthesia, flexion to the elbow, abduction to the arm, traction to the limb, counter traction in axillary, counter traction by assistant. But then we do longitudinal traction followed by external rotation of the shoulder. Then we adduct and internally rotate the shoulder. By the adduction and internal rotation, usually we get clear click of reduction and the shoulder restore its position. This is the common, what we call it, Kocher method. The other here by gravity will last well Hippocratic method. Hippocratic method من طريقة تاريخية يعني ما عادت تستخدم. التريتمنت باي جرافيتي المريض ينام على بطنه والlimb dependent and freely out of the bed, and the patient gives sedation by bethidine or stimutil, and we allow him to allow the limb to use spontaneously by the gravity of the limb. This take time, need observation usually. This. عندنا كمان trouble in children, we call it pulled elbow. طفل يمشي مع أمه ومع أبوه أو يلاعب خاله أو عمه. He apply longitudinal traction يعني يشيله من إيده فيصير longitudinal traction to the forearm. By the longitudinal traction of the forearm, the annular ligament will enter between the head of radius and the capitulum, and the child start to cry. This common injury, and usually treatment is easy. You just apply supination of the forearm with some traction. This injury is common and usually recurrent، وهي تختفي من يصبح عمر الطفل أكثر من 5 سنوات. دائما هي تصير الأطفال بين السنتين والخمس سنوات. من يكبرون أكثر تختفي هذه الظاهرة. This is dislocation, posterior dislocation of the elbow joint, and you can see this is the posterior. عادة الريفرنس معناتنا if the limb displaces the distal part was displaced posteriorly, we name it as posterior. So this is posterior dislocation of elbow joint. The complication of this injury، هذا الانجري الثري نيرف الموجودين بالإلبو هم قريبين عليه. الراديال نيرف انجري ممكن أن يصير، والألنر نيرف ممكن أن يصير، والميديان ممكن أن يصير. ودائما واحد يتذكر أنه possibility to get injury to the brachial artery. So these are the common important complications اللي ممكن أن تصير. The reduction should be urgent. Well, reduction similar to that of supracondylar traction here. Traction and counter traction for 2 minutes in semi-flex position, and then we try to push the distal fragment over the proximal segment, and we assess any lateral and medial instability of the shoulder, of elbow. Then we apply back slab for 3 weeks, وبعدين start active mobilization. بالelbow injuries, always we should not use passive exercise, we should just use active exercise. Any passive exercise will lead to myositis ossificans. This is displaced fracture in the metaphyseal region of the radius. And you can see there is metaphyseal fracture in the end of the radius. This is what we call it metaphyseal region. The children usually we name the fracture diaphyseal, metaphyseal, epiphyseal. يعني ما نستخدم كوليز سميث بالchildren. السميث والكوليز يستخدم للأدلت. And this is typical Colles fracture. Typical Colles fracture. هذا نسميه dinner fork deformity. Dinner fork deformity. And the fracture displaced laterally and dorsally. The Colles fracture هو fracture in the distal edge of radius displaced dorsally and laterally with or without fracture in styloprocessal form. هي واحدة من الcommon, the most common fracture in human. عادة التريتمنت مالته conservative. And this is the Colles fracture. And this is compared with the metaphyseal fracture in the children. هذه in the distal edge of radius، بينما هذا يكون بالميتافيسيس ويكون اكو epiphyseal plate and ground skeleton. This patient had history of full and outstretched hand, and he had painful snowflakes. This is the site of tenderness. And you can see in the X-ray there's a fracture in the scaphoid bone. How we can hold this fracture? Usually we hold it in POP in semi, what we call it glass holding position for at least 8 weeks. ذكروا دائما السكافويد at least 8 weeks. لأنه السكافويد اليونيون مالته usually delayed. It need long time to unite it. But always need long time. But at least 8 weeks, the splinting should be continued. This is deformity of the finger. We call it mallet finger. Mallet finger result from rupture of extensor mechanism. Either cut or rupture of extensor tendon.
العفو دكتور، بس سؤال.
Yes.
دكتور بالنسبة للوقت يعني انتم الدكاترة عند جامعة الكسور مختلفين بالوقت اللي تخلون به بلاستر اوف باريس. يعني انت مثلا بالكافو اذا انت قلت 8، دكتور يقظان دكتور سهر يعني قالوا على 6.
لا
يعني
لا
هالشيء راح يصير؟
لا
راح
احنا
يصير هالشيء؟
بالنسبه بالتصليح هذا إنه ما مهمات، بس انت كقاعده كل العالم مجمع بالكونسرفتيف تريتمنت بانه اقل مده تبقى، اكثر الكتب تبقى تذكر بانه اقل مده هي 8 اسابيع.
تمام دكتور.
مده هي 8 اسابيع، اقل مده هي 8 اسابيع. يعني لانه هذا المكان اليونيون مالته بطيء، بتحتاج لونج ديوريشن. يعني
تمام دكتور.
تنذكر 6 اسابيع وتاخذ المريض اشعه وتتاكد من عنده، وبعدين تخلي له جبسونه بلو البو ان جلاس هولدنج بوزيشن. فيعني بالنسبه لكم اخذوا اطول المده، لانه هذا المكان الالتئام مالته بطيء جدا. يعني لو احنا طبقنا القاعده اللي نستخدمها ببيركن بالبدايه، فكل الاشياء اللي تاخر الالتئام موجوده. دائما هو يكون ادلت، فلازم تضرب المده في 2 مو الشكل، والفراكشر ترانسفيرس تضربها في 2. فلو احنا طبقنا بيركن فورمولا اللي اخذناها بدايه اول محاضره بالفراكشر، فلازم يحتاج 12 اسبوع حتى يلتئم هذا الفراكشر. فهذا
تمام دكتور.
اليونيون مالته بطيء، التريتمنت شود بي برولونج. فدائما انتم اخذوا المده الاطول، يعني على الاقل لازم يكون 2 شهر. احنا مرضانا دائما ما يتحملون، يعني بقي له 5 اسبوع ويشيله ويزته، وبعدين يصيرون كلهم نن يونيون وكل يوم يجي ريده توجع، لانه ما يتحملون البرولونج تايم اوف سبلنت. هو 95% او 90% كان بتريتد كونزرفاتيفلي باي برولونج ثيرابي، واللي يصيرون نن يونيون او هم اصلا ديسبليست من البدايه يحتاجون اوبراتيف تريتمنت. واضح؟
واضح دكتور.
Yes. This is what we call it mallet finger. هي اما رابتر للاكستنسر ميكانيزم او اكستنسر تندن، اما ان ينقص بسكين او during movement it will rupture spontaneously، بلخص من واحد ينفذ شرتف قوي، او ممكن ان تصير اذا كان واحد عنده روماتويد ارثرايتس، فالرابتشر اوف تندن will occur easily. فاما rupture of tendon او cut by knife or avulsion of the bone، يعني by sudden contraction against resistance. But this will lead to flexion deformity of the distal phalanges. We call it mallet finger. هي الفليكشن، يصير الفلكسر هنا متصل فيصير قوي فيسحب باتجاه الفليكشن، الاكستنسر ميكانيزم يروح. التريتمنت هي هايبر اكستنشن، سبلنت ان هايبر اكستنشن for at least 6 weeks. لازم نخليه سبلنت in at least 6 weeks in hyperextension. هذا ننتظر إلى أن يصير healing and fibrosis of the tendon in shortest position. Then we remove the splint and we start active exercise. This is common anomaly or common congenital condition, congenital disease of the foot. We name it as a club foot. اللي يعني طبيا احنا نسميها congenital talipes equina virus. المؤسف انه هذه المحاضره دائما تصير اخير محاضره، وبالارثوبيديك هو الكومن تو congenital anomaly او congenital disease او developmental disease هم الدي دي اتش والكلاب فوت. الكلاب فوت الطفل يجي عند الفوت deviated medially، الفور ارم supinated، الهيل in virus. This we call it club foot. This club foot is very common. تصير حوالي من 2 إلى 5 بالألف من الأطفال يولدون بهذه الديفورميتي، والدايجنوسيس usually by inspection. وهي تنقسم إلى مجموعتين، قسم يعني postural نتيجة التايت position in the uterus، وقسم يكون structural. البوستشرال usually correctable in clinical examination، while the structural is not correctable by a clinical examination. The treatment should start by yearly repeated multiple splintage and gradual correction. If the correction failed, we should go to the operative treatment to correct the deformity in the foot. Surgical treatment usually depend on the age of the child at treatment. Different way of treatment. Most of them is soft tissue release. This is not varus, this is valgus deformity of the foot. The foot deviated away from midline. We name it as valgus deformity. Valgus deformity most of the time is benign and might associated with DDH sometime. It can result from neuromuscular imbalance of the foot. Valgus deformity also a common deformity in the foot. The treatment of valgus deformity usually treat the cause. Most of them is transient and disappear spontaneously. This is varus deformity of the big toe. Varus deformity of the big toe with the prominence of the head of the first metatarsal. عادة ما يكون عادة bunion will develop over this deformity, and this bunion or bursa might inflame, lead to bursitis and pain in the area. This is common, very common anomaly in the foot, where more common in female. Will cause of it here tight shoes. The most predisposing factor here, tight shoes. If it's cause symptom, it can be treated surgically by different way of surgical treatment. This is the X-ray example of pelvic fracture. This is what we call it open book fracture. Both pelvis separated away from each other with diastasis of the symphysis pubis. Diastasis of symphysis pubis. This is a variety of unstable fracture pelvis, might associated with injury to the viscera, urethra near to this area and liable to get injury. The bladder liable to get injury, genital tracts, the large bowel, and the organ, the visceral organ can be injured, the intestine. This type of unstable fracture pelvis. If there is doubt of urethral injury, we ask the patient to urinate and he cannot urinate, or there's bleeding in the urethral meatus. In this condition, there is possibility of urethral injury. In this condition, we should consult urologist. We should consult urologist. If there is no urologist in the area, we should do suprapubic cystostomy. We should not put catheter, and the catheter in the urethra will change the partial fracture, partial tear of the urethra to complete tear of urethra. We should not catheterize the patient if they can occur without of urethral injury. We leave it to urologist. This is another fracture pelvis, and you can see the both pubic rami, superior and inferior, superior and inferior. This is what we call a tetraramic fracture. This is another unstable injury, but the weight bearing is not involved here. The weight bearing site not involved. The treatment of this condition usually a bed rest until the pain subsides, or then we gradually mobilize the patient. And you can see the X-ray of the same patient. There's chest tube in the chest. Pelvic injury عادة ما يكون associated with other injury, including chest injury, head injury. The most important, we should exclude more serious injury, like chest with head injuries. The fracture pelvis can associated with injury to the diaphragm, visceral injury, splenic injury, liver injury. All this might occur with association with fracture pelvis. This is the position of driver. In this position, if there's car accident and sudden deceleration and dashboard injury, the dashboard might push the femur backward, and this lead to posterior dislocation of the hip joint. A patient who had posterior dislocation of the hip joint, usually the limb is short, adducted, internally rotated, and short, semi-flexed. And this is the typical picture of the patient who had posterior dislocation, a limb semi-flexed, adducted, short, and internally rotated. And this is the X-ray. You can see the head outside the acetabular and migrated upward and posteriorly. The reduction should be done under general anesthesia with muscle relaxation. The patient we put the patient on the ground, and we should flex the hip and flex the knee. The assistant fix the pelvis, and we apply longitudinal retraction with external rotation. Adatan, the reduction will achieved with the Frank click and limb become symmetrical. And we assess the stability of the limb by flexion, extension, adduction, abduction to assess the movement of the hip following the reduction. This is position of prominent bone. If the patient sleep for a long time in supine position, this position will lead to ulceration of skin between prominent bone and the bed. The skin will compress and the skin ulcerated and lead to what we call it bed sore. Bed sore is easy. It is easy to prevent and difficult to treat. Always we should check this position and prevent prolonged bed. And if we have patients who had sleep in the bed for long duration, always every 2 hours we should change the position of the limb. Otherwise, bed sore will develop in these patients. This is common in paraplegic patients and old age group, and after fracture or injury to with the spinal cord. There's swelling of the knee joint. There's swelling of the knee joint. Mentioned 3 causes of acute knee swelling. The common cause of acute knee swelling is traumatic synovitis. Any trauma might lead to swelling of the knee joint, either collection of fluid, clear fluid, traumatic synovitis, or blood in the joint. We name it as hemoerythrosis. The other cause of
infection.
No, infection, yes.
Infection, osteoarthritis.
Septic arthritis. Septic arthritis. الأوستيوارثرايتس عادة تكوز chronic knee swelling. الأذر هو الجاوت ممكن أن يسوي لنا acute knee swelling. سيدو جاوت ممكن أن يسوي لنا acute knee swelling. الكرونيك knee swelling.
دكتور ممكن الروماتويد
الروماتويد يسوي لنا chronic knee swelling. والأوستيوارثرايتس أيضا يسوي لنا chronic knee swelling. بينما الأكيوت هو ممكن أن يكون traumatic، ممكن أن يكون يعني gout or pseudo gout or infection. swelling in the knee joint ممكن أن يكون anterior وممكن أن يكون posterior. anterior ممكن أن يكون بشكل swelling of the whole joint مثل ما ذكرنا، ممكن أن يكون acute chronic whole joint swelling، وممكن يكون localized anterior مثل البريباتيلر بيرسا، infrabatellar bursa. All this is swelling in the anterior part of the knee joint. ممكن أن يكون swelling posterior to the knee joint in the popliteal fossa. And the common swelling in the popliteal fossa is the Baker cyst. The Baker cyst were herniation of synovial fluid posteriorly in the popliteal fossa, it results from mostly from rheumatoid arthritis, it results from osteoarthritis, or result from tuberculosis. We name it as Baker cyst. Baker cyst was herniation of synovial fluid posteriorly in the medial part of the popliteal fossa. We name it as Baker cyst. الأذر swelling اللي ممكن أن يصير بالبوبليتيال فوسا هو semimembranosus bursa. Semimembranosus bursa will occur medially on the medial part of the popliteal fossa along the semimembranosus tendon. Usually affect children and self-limiting this condition. The other more dangerous swelling هو الانفكشن ممكن أن يكون abscess in popliteal fossa. والmost dangerous هو aneurysm of the popliteal artery. This, if we drain it as we thought that this is an abscess or cyst, this might lead to massive bleeding, and it will very, very difficult to control the bleeding. Always we should think that there is possibility of aneurysm in the popliteal fossa. الأنيوريزم عادة يكون بثريل وبلساتing, but sometimes if there is thrombosis of the aneurysm, usually there is no thrill and no pulsation. Always we should think of possibility of aneurysm sometime, even it is rare. Now the swelling of the huge tumor, احنا مرضانا ممكن ان يجون بصور مثل هالصور هذه المتأخرة, even ulceration sometime. This picture taken for a patient with swelling redness on the medial side of the knee joint. This patient had history of previous infection and previous surgery, and he has fever swelling. This is what we call it acute and chronic osteomyelitis. يعني عندك previously chronic osteomyelitis, and then he get flare up of the infection. This is what we call it acute and chronic osteomyelitis. And there's sinus which discharge was from this point. For this case of acute flare-up of infection in chronic osteomyelitis, or what we call it acute and chronic osteomyelitis. This is bilateral valgus knee deformity. You can see both knee is deviated away from midline. The valgus deformity either physiological or it results from dysplasia of the bone or softening of the bone. البون softening disease اللي ممكن يسوي لنا valgus deformity of the bone هو usually renal ricket, especially glomerular type, يعني damage to the glomeruli, which start عادة later on in the childhood, يعني not immediately. عادة 3-4 years later, if the child develop glomerulonephritis and renal ricket, this renal ricket will go toward valgus deformity rather than toward varus deformity. بينما اللي عنده tubular ricket, which start immediately after birth, usually the varus deformity will augment it and they will get severe varus deformity of the knee joint. الكوز مثل ما ذكرنا mention cause, الcommon cause هي physiological, وممكن أن يكون dysplasia أو ممكن أن يكون bone softening disease وممكن أن يكون rheumatoid arthritis. This is severe varus deformity. This is severe varus deformity. ونفس الشيء ممكن أن يكونون physiological mild بالchildren, وإذا يكونون severe ممكن أن يكون نتيجة dysplasia we name it as blunt disease, أو ممكن أن يكون severe ricket type بالذات tubular type of ricket مثل الهايبوفوسفاتيميا. This is how we do clinical examination for knee joint looking for meniscus injury. Patient prone, and we do flexion to the knee, and we apply vertical compression to the knee joint by vertical compression, or we call it grinding or compression test. We do with the compression medial or internal rotation. If the patient develop pain, this indicates lateral meniscus injury. And then we do compression with external rotation of the foot If the patient develop pain, this indicate medial meniscus injury. This is what we call it compression test or grinding test in other name, or we name it as Abley test. This test used for assessment of meniscus injury بلخص بالشباب الرياضيين اللي ممكن أن يصيرون meniscus injury بالذات لعيب القدم. Describe the radiological finding. You can see there is a fracture in the patella. The patella is comminuted and there is wide gap in the patella. This results from what we call it indirect fracture of patella. عادة ما يكون all the soft tissue is injured except the skin and there is defect in the extensor mechanism. Such injury must be treated by surgical treatment by over-reduction and internal fixation to maintain the extensor mechanism of the new joint. How we differentiate the direct from indirect injury? The direct injury, usually there's intact extensor mechanism, بينما indirect يكون displaced and there is no any extensor mechanism. All extensor mechanism is ruptured. يعني كل الليجمنت around the extensor mechanism with attachment of the retinaculum of the extensor mechanism is injured. فيكون فقط السكن directly to the bone. How to differentiate it? Clinically, we ask the patient to elevate his legs straight. If he can do it, this excludes indirect injury. The patient, if he had direct injury, can